Good afternoon, everyone, and welcome back to the Dean's Leaders in Lagniappe Lecture Series, where we welcome public health leaders to share their innovations, ideas, leadership values that got them to where they are today. I'm your host, Thomas LaVeist. I think you all know that. As we get started, I wanted to briefly ground us in the work that we're here to address. In the land that we inhabit, New Orleans, originally known as Balbacha, is situated in the American Gulf South, historically and presently the epicenter for inequalities in our nation. If we are to make our world a more equitable one, we must include and center the places and communities subjected to the greatest inequalities, in part because the solutions we seek live in these exact communities. The origins of this lecture series come from a school-wide desire to give our students the tools and experiences needed to become the next wave of innovative leaders. Through these opportunities to meet and learn from some of the most distinguished leaders in public health, we aim to build a bridge between our future leaders and our current ones. Today's lecture is one that I've been particularly excited about, but it's a little bit different. As you know, in the past, our lecturers have been deans of other public health schools who have talked about their experience, or people who are currently in leadership roles. But today's session is responding to a set of conversations that I've been having with our students over the years. I often ask students kind of, what is your plan for your degree? What do you plan to do with this public health training you're getting? And typically I get some variation on this. When I graduate, I'm going to go back to my under-resourced community that's got public health challenges that led me to go into public health in the first place. And then I'm going to set up a nonprofit to work on fixing those problems. And my response is always the same. Why a nonprofit? Why is a nonprofit the go-to? I mean, in public health, we get grants, we develop interventions, we work with communities, we deploy the interventions, we document that the interventions actually work and make things better for people's lives and for the communities. And then the grant ends and the project ends. And then we move on to the next project and the next grant. And we have all these great ideas of things that we know and have documented actually can make a difference. And nonprofits often struggle to be able to be sustainable because they have to rely on grant support. And so that's why we've been meeting with the School of Business. We have faculty here from public health and myself. We've been meeting with School of Business to talk about building sustainable models in public health and how we can build models that are sustainable within communities. And you'll be hearing more about that. But today is particularly exciting because it fits very nicely with that whole idea, because we have two women that I admire greatly who are public health leaders in their own right and who have had distinguished careers in public health, but have now both created for-profit businesses to try to address public health problems. And I want you to be exposed to them and learn more about what they do so that you can see that this is an option for public health. This is a way that we could build sustainable programs. So our first guest is Dr. Rebekah Gee, visionary CEO and founder of Nest Health, the first value-based healthcare provider built for whole families, and an OBGYN. Dr. Gee previously served as Secretary of Louisiana Health Department, where she oversaw half the state's budget and the implementation of Medicaid expansion, which has extended health insurance coverage to over 600,000 Louisianans. Our second speaker will be Adaeze Enekwechi, a longtime healthcare executive and current CEO of Cayaba Care. Got it? Cayaba Care, okay. To this role, Dr. Enekwechi brings extensive experience in healthcare policy, research, and management. Previously, she spent many years in the federal policy roles at the Congressional Budget Office, the Medicaid Payment Advisory Commission, and she was the head of health programs at the for the White House Office of Management and Budget under the Obama administration. And at that time, she was in charge of the health budget of the United States. So it's a fairly sized budget, I think. So we're going to do things a little bit differently. So they're going to each make a few remarks. And instead of giving the full lectures that you're used to, they're going to give just a brief description of their businesses and what those businesses do. And then we're going to have a conversation about how they came about doing the work that they're doing. And then we'll open it up for you to ask your questions. So I'll turn to Dr. Gee first and ask you to address our audience.
Yeah. Thank you, Dean. Well, I got my speaker on too. Thank you, Dean LaVeist. You are an absolutely, oh, thank you. Oh, well, I can also be phenomenal human being, leader, and friend. And I could not be more delighted than to be here with you all. I am adjunct faculty at Tulane. So I also hope you'll adopt me today and maybe let me keep my unpaid role here.
We'll even get you a hat.
Okay, good. So I'll just say, having been in my most of my career, I'm an OBGYN, so I take care of patients, but I also spent most of my time thinking about how to improve maternal and child health. And at the state, and have worked with some of you in this room to do that, got frustrated at the end of it by the fact that what I came to understand is that if you don't have healthy women, you don't have healthy children. And that everything we can do in pregnancy is fine, but it's not enough. If you're already sick and you get pregnant, it is not enough. We have to have longitudinal reproductive health care for women, and it has to transcend pregnancy. There is a before, there's a during, and there's an after. And I didn't see any company focusing on that longitudinal women's health care. And furthermore, I realized that the Trojan horse to mom is her children, right? So if we're going to really get moms engaged in their care, we've got to take care of their kids. And further, if we're going to have healthy children, oh, wow, you have to have a healthy home and a healthy caregiver. So how come our models are pediatrics over here, mothers over here, dads over here, psychiatry over here, social services over here? Never the twain shall meet. And so Nest brings all of that together. And the goal is to change generational health, right? To really, this is a New Orleans company. As I think about our city, I look around, and particularly during COVID, saw so much violence and challenges in this city, and said, what if someone had helped all the moms of New Orleans when they needed that? Would we have crime? Would we have problems? Probably not. Would we have a lot more people employed? Yes. And we'd have healthier people. So I think that we have now 60 years into Medicaid. We realize that so much of it, I believe in Medicaid. I believe it's critically important. And we've also failed miserably. We've failed miserably to create healthier moms and kids. We haven't done it. I mean, you all know the data. You know that maternal mortality is getting worse. Our child health metrics are getting worse. And why? About half of our American kids and moms cannot get to care, period. We just looked at the TMSIS national data, 50 million incidences. Almost 50% of these children and their moms did not get primary care for 3 consecutive years. So I think if anyone thinks that the solution is more brick and mortar and more of what we're doing today, we are not looking at the data. So again, you know these numbers, but the brick and mortar systems work for some. They don't work well for anyone, I would argue, but they certainly don't work if you don't have a car and if you have other social needs. So what does Nest do? Nest is a Medicaid-focused company that works with health plans to identify all of the families. We look at families as a unit because we know you can't have a healthy child without a healthy home. You can't have a healthy mom if you don't take care of her needs with her children. And so we do the entire family. We are the primary care provider. We send into the home. So it's not a virtual solution. We are in home with providers putting vaccines in arms. Here in New Orleans, we put 1,500 in arms last year. We are now with 30,000 patients across Arizona and Louisiana at 6 different offices and growing. And what we do is we comprehensively care for the whole family. That means primary care for everyone. It means behavioral health for everyone. We just started Nest Rooted Recovery, which is in-home Suboxone. And we are doing, we launched Nest Origin 2 weeks ago, which is prenatal care at home with midwives. So they do not have to go into an office at all, except for the anatomy scan and for the delivery. And then we do social services and behavioral health. So full-time social workers, psychiatry, really helping through all of those things. I talked about the team. We have 24/7 care. I'll get through this. How do we find people? We focus on people that are not otherwise getting care. Results, I think critically important. So now 28,000 lives, we have 60% ER reduction. We have saved our plan, double our fees. We have engaged and reached 75% of the population for whom the health plan had no working phone number. Again, I think this is because of the family approach. I have 5 children. If we were looking to find me, we would be able to look at all of their data with which to find me, right? Currently, most engagement strategies are, I'm looking for a person, let me find their data. Well, in the Nest model, I'm looking for a family. If anyone in that family engages in any way with a resource that collects new information, we are going to find you. We are 99, it's not on this, 99 NPS score. We are the only concierge care Medicaid practice in the US that is focused on kids. So we are delighting our customers. Part of it is that I don't know if anyone has been to walked a patient through a Medicaid visit and what they go through, especially in this town. But it is not often pleasant. They are not often the priority, and Medicaid patients are not often treated like the goddesses and gods that they should be. And so that's what we do with people who look like, speak like, and come from the community in which our patients live. It's cost savings, all of it. We can talk about this later. King Families is just a great example. We can talk about that later. I'm going to stop showing slides so that Adaeze can come up. But I think the fundamental reason for starting this business is I came to the conclusion that we needed change, and it wasn't going to be a health plan, and it wasn't going to be the auctioneers of the world or LCMCs or even Two-Lanes, right? Because they are invested in their specialist and their care model and their things and their fancy equipment and their, their robot operating rooms, right? And that's great, but they're not focused on how can we care for those who are in the shadows in ways that have margins that are sometimes a little bit more tricky to solve for. And so that's why a Medicaid focused company with a different care model, I think was so critical to changing the narrative. And so it's partly our work is not just about caring for the people we care for, but also actively challenging policymakers to say, is it okay that half of American kids on Medicaid, which is a quarter of American kids, did not get hearing, vision, vaccines, well visits? That ought to make us all really worried about our future, and there should be more done about it. So with that, I will look forward to comments later.
Good afternoon, Tulane. Thank you very much, Tom, for inviting me, and it's nice to see actually a quite full room. I actually was not prepared to talk with slides, but since Rebekah had slides, I had to show, and I don't know how to, I had to show you my logo at least. So I'm the CEO. My name is Adaeze Enekwechi. I have a PhD in health econ, health outcomes from University of Iowa, did my postdoc at the University of Chicago, recovering academic. Because once I left academia, I stayed in government as a policy official in a number of different capacities. I think Tom rattled off some of the acronyms that you all may be familiar with. So I'm still DC based, and ended up after running actually a fairly sizable consulting company called Impact International. Once we did very well, we did a lot of work for HHS, which included ARC, CMS, CMCS, a number of other acronyms you're probably familiar with. The owner decided to sell the company and said, since you're the president of this company, you are going to sell the company. So I was the tip of the spear in an M&A process. North of $100 million. Suddenly I'm meeting with every interested strategic or private equity investor that was interested in buying this company, 13 management presentations while running the company during COVID. Somehow we landed that plane and had a very successful transaction. And I found myself after that getting calls from private equity firms. And I'll tell this story by way of introduction. The first call came from someone I didn't know. He said, I hear you're about to say yes to another CEO role. And I said, why do you know that? These are confidential conversations when you're part of a search. He says, oh, it's healthcare. Nothing is confidential. I said, okay. He said, well, I'm calling you to see if you would consider joining Welsh Carson. I said, do you know who I am? Welsh is a private equity firm, one of the white shoe ones in New York. He said, yes. I said, do you know I'm a woman? He said, yes. I said, do you know I'm Black? He said, yes. Do you know I worked for a Democrat? like in a pretty high profile role, and I care about, have you seen anything I've ever written about Medicaid and vulnerable populations? He says, we're self-aware. We know how we look. And I know I'm calling the right person, and I think you're the right person for this role. And so I ended up joining a PE firm as a partner and learned a lot. So I think we can talk about that when we sit down, but that's a little bit of an introduction to me as someone who has certainly wandered off the beaten path. I was supposed to be a faculty member quietly, when I was training, and that did not happen. I'm now the CEO of a company called Cayaba Care, which is a maternal health care wraparound services solution. We're actually going to be rebranding. And so on Monday, we will be known as Lagniappe Care. You are hearing it here first, but you'll see new colors, new branding, new everything. And that's happening all for a very good reason. Rebekah has already given us a quick lay of the land in terms of why we would have a company that does this kind of work. She is focused on the family as a unit. The unit of analysis or service for us is the mom, but increasingly the baby as well, soon after the baby's born. So this is not the group that we need to explain some of the root causes and why we find ourselves. And this is, you could tell this is an academic. One of the venture folks will have lots of pictures, which makes me I find them disorienting. I'd like to read. Cayaba is a full range maternal health support program. We basically provide all the services, the wraparound services that you would not get when you go to your physician. So if you think about Medicaid, which is the population we serve, many of the members we serve have a whole host of challenges that would threaten the success of their pregnancy at any given time. So it's one thing to measure blood pressure, which I think, lots of folks want to do, just measure the blood pressure, make sure blood pressure is under control. If that were the only concern, we would probably not have some of the outcomes that we have. In Philadelphia, we had many women who did not have heat in the winter. We have people who are food insecure. We have people who are housing insecure, transportation insecure, violence in the home, acute depression, none of which are necessarily treated or addressed when you go to visit your doctor. And so we hire medical assistants, community health workers, and we train them to become maternity navigators, to do all of those things that we know that our members need in order to, fulfill or experience a successful pregnancy. We are hybrid. Rebekah mentioned this. They visit in the home. I think our two companies are the only ones I know who actually visit people in the home. This group may be surprised to learn that out in the industry, lots of people have been convinced that all you need is an app in order to have drastically improved outcomes in any disease category. I think we learned that certainly for psych and psychology or therapy, behavioral health, that yes, having the ability to meet with your therapist virtually is highly efficacious, if not as efficacious as in person. I don't know that that can be extrapolated to every single thing in healthcare, and that's certainly the case in maternal health. So we visit our moms in the home. We visit with them in the Walmart parking lot. If that is where she is ready to meet with you, that's where our navigators will go. Or maybe it's the Target coffee shop, wherever they are comfortable meeting, so that you build trust and you start from a foundation of trust. That is frankly what is missing in maternal health. It's why we have such poor outcomes, is that there's no trust in the system. And I'll give you, I think rather than going through slides, I'm happy to sort of walk you through some of the things we've heard from our members. They will tell you, I went to the doctor after a long day of work. I had my uniform or whatever sort of marker. I took 2 buses to get to the doctor's office, and when I got there, the first question they asked me is if I'm on drugs and what drugs I'm on. And they asked me that question 5 different times, and I don't want to go back. And you can only imagine if you were to get that question, but in fact, what you are is tired. and exhausted, you would not want to go back. So we have members who are tired of feeling gaslighted, insulted, questions or conversations directed at them that are in many ways dehumanizing. And that is certainly not the foundation upon which you can build trust. So this is what we are anchoring on. It's really that trust and empathy based engagement. We have to do a lot of work to reach and enroll and keep our Medicaid members in the model. The reason this work is hard is that if you build it, they will not necessarily come. You have to go find them. You have to convince them that this is yet one more thing that's worth them sort of engaging in. You have to sort of, work with them to bring their children into the fold, if that's their spouses or partners. And so that's what makes this work very challenging, but also very rewarding. And I'm just showing you sort of the standard Cayaba model. We work in pods, navigators, nurses, lactation consultants. A lot of judgment goes into feeding the baby and how you do it and when you do it. So removing as much of that as we can through education and compassionate engagement. I will stop there. We had 5 minutes, and I know I'm already over 5 minutes, but I'm happy to talk about outcomes. But this was supposed to be about leadership. And so Tom's prompt, which he did not know that he wrote, is about us, how we lead and how we fell into these leadership roles that are quite divergent from perhaps our original training. But frankly, in keeping, I think a health services researcher, a health economist is the best person to build some of these companies. We are doing it with great intentionality, with evidence, and trying to do the right thing as opposed to some of the shortcuts that we see in industry. So with that, I'll transition.
You've both built distinguished careers in public health and government before becoming founders and CEOs. What moment of realization or what convinced you that building a company was the right next move?
You want to start? You want me to start? Yeah. I think a lot of people like to tell a story about their career, and it's very deliberate, and this happened and then this happened. And so I don't know that, I think this chose me, which is kind of interesting, just like New Orleans chose me. Just like government chose. I mean, I wanted to do federal government. I ended up in state government because I ended up here. And so I think the for-profit sector chose me as well. I had a bunch of ideas. I mean, my story is pretty unusual in that I'd had this policy background. I had been known for doing disruptive innovation in government, things like this, the hepatitis C payment model, Plan B reform, all kinds of the Medicaid expansion, how we did it. So people kind of knew me, okay, this lady breaks things and maybe fixes them, hopefully. And she's provocative. And so I had a bunch of ideas coming out of state government about what didn't work and what needed to change. And I ended up meeting a venture capitalist and said, here are all these ideas. Here's what I think should change. And he said to me, well, why don't you? And at the time I was thinking about going on a board or maybe going to work for one. He said, well, I believe in you. Why don't I fund you to start one? So that literally was my story. But I was already moving towards private sector. All of the things I was looking at were private sector, because I do think one of the things I kept hearing was, oh, well, you'd be a great leader of such and such, but you don't have P&L experience. Oh, you'd be a great such and such, but do you really have experience leading in government? Even though, when I was secretary, I had a staff of 7,500 people. We ran 2,000 hospital beds. And so I wanted to, I hate to be told I can't do something. And so part of I think the goal was to say, okay, I have P&L. Okay, good. I did it. All right. No more of that. So that as I round out my career, I think about all the things I can do. I can be a provider. I can understand policy and move policy. But frankly, I think I'd hit up against moving policy about as much as one can, right? Expanding Medicaid, changing all the rules around maternity payment. And then at some point, it's like, okay, well, someone actually has to do something. And it's not going to be government that does it.
Okay. So, of course, P&L is profit and loss, and it refers to managing a budget. Yeah.
So the question again is how I got into running this company.
Yeah. How did this happen?
So again, I think in some ways it was a fluke. I was on a board of my first board of a board service on a venture-backed company is a company called TIA, women's health company. Yeah, I was on that board, and it was sort of my first exposure. I was on other boards, larger entities. TIA is venture, which is different. And so and I was a partner at a PE firm. I was looking for a maternal health company to invest in from a private equity perspective. I know private equity has, it connotes negative things for sure. But if you do it right, it really can be it just immense accelerator, an expansion vehicle for the right company. And so, but you would know that if you're on the inside, and you would know sort of which levers to pull. So I was looking for a maternal health or women's health company to invest in. And that's how the venture folks got to know me. I didn't know them. And so one member of the syndicate on this company, Cayaba, says, I think you're the syndicate, the investor, the group of investors who have invested into the company and were therefore on the board as board directors or observers. She says, I think you're the CEO we've been looking for, which I said, that's really cute. I don't run early stage. I don't know what to do with a Series A company. Series A company is like coffee in a private equity firm. So just in terms of scale. And, she said, we'll just have conversations. And I started to have conversations. And because I had diligenced this space, I knew that Cayaba was top of the list in terms of the model. So in terms of credible models that are doing the right thing, I knew of this company. Didn't know anything about the founder or any management team. But the question as an investment or an investable asset was that the team at the time was unbackable. That means a lot of very bad things. So great model, great company, great concept, unbackable team at the time, as it was classified, basically meant that unless the team changed out, investors weren't going to look at them. And so a lot of great companies die on the vine over whether it's the management team, bad investors, board members or board directors who function as mercenaries at times. And I found I didn't want to participate in that. Long story short, I ended up being the CEO, and there began the journey of running a venture, Series A, venture-backed company, which was never in my plan, but it's what I'm doing, and it's pretty incredible.
Mm-hmm. And so what leadership skills from public health did you find most useful and you moved into this private sector world?
Yeah. I can start.
Yeah.
Break. So leadership skills, I actually think that it's sector agnostic. I think for me, to be a good leader requires a number of attributes. I think the first one, though, is humility. If you are humble, or at least you bring a healthy dose of humility to your work, you will be better at building the right team. So first thing is you need really the right people on the bus. And to do that, you have to acknowledge that you don't know everything. You won't know everything. You need perhaps a strong salesperson, a strong finance lead, a strong head of people, for example. At the same time, you need to be very confident, right? Because you need to sell this business. You are the face of the company. You are, especially in this business, we are selling to health plans where their default is no. They walk in skeptical. And so if you're walking in skeptical, you have to overcome the skepticism that they have. You have to prove to them, at least before they sign a contract, that they might see a 3x return. For us, it's 3. I'm starting to hear 5, right, on an investment like this. And so humility and confidence, and I think a recognition or belief in what you are building. I don't know that it's possible to do this work without believing every second of the day in what we are building and that this is the right thing to do.
Well, and Nest Health is very much can you guys hear me? A public health story. I think, part of the reason why I created Nest was because I was on the board. I used to teach healthcare quality at LSU School of Public Health and was very much, and prior to that ran quality initiatives. And so I was ingrained in me from my public health training was, if you can't measure it, you can't manage it. And if you don't have a logic model as to what intervention you are doing that will lead to change, you're going to end up with fluffy stuff. Like things like at the health department, we decided to give out, $8 million, $8 million worth of, vitamins and we hoped it would improve birth outcomes. Well, that is the kind of stuff that a lot of these startup founders do. They're 25-year-old venture bros and they think they know what's up. but they actually don't have the discipline of a public health training to really think about that. So part of the reason that started is I asked Don Berwick, who's been one of my mentors and someone I greatly admire, where's the best primary care? I think we need to improve primary care. And he said, we'll go to Alaska. And I did. And I found a program in Alaska that had this comprehensive family at the center, behaviorist on every team, child development is critical, mom's longitudinal care. And I was like, that's it. And it was also, I had been in a public health setting, had led Title V home visiting programs. I was CMO for that. So I knew that we had these amazing home visiting programs funded by public health that have not scaled, are not particularly sustainable, and that I had also led Medicaid. And I thought, well, what if Medicaid and public health had a baby? Right? Could we actually make whatever this is sustainable? So it is very much came out of this belief that public health matters, public health works, that the intervention of someone being in a home is an economically viable and important intervention, and yet the ways that we're addressing it through parents as teachers, nurse-family partnership hasn't changed outcomes at a population level and will not change outcomes at a population level. So if we're going to do it, we have to figure out how to do it sustainably, profitably, and in ways that that are not reliant on government. I think we all know what's been happening in the past few years, right? And a lot of things have been canceled that we all wish were here. If it's a for-profit company, no one can do that to you, period. So that's why for-profit is neat. Yeah.
So let me ask you this question. Let me push you both a little bit. So you had access to venture capitals and you had Don Berwick on speed dial.
Yeah.
So for those of us that don't have that, how would they transition into the work you're doing?
I'll just start just because we hire a lot of people, and I know you do too. I think most people don't get a chance to start a company. The reason I was able to is because I'd been a health secretary, et cetera, et cetera. So that's not, and I actually don't recommend it. Starting your own company is really, really hard. So I would actually say don't do that. I think, there's lots of opportunities to work at startups. So the way to do it. Huh?
Ignore that part. Starting a nonprofit, starting a nonprofit is not easy either.
Well,
No.
that's true, but
So it's going to be hard either way.
I think what you're doing is important here. I had the opportunity 2 weeks ago to speak to the MPH students at Yale who are very oriented around the financial models. And I do think that you ought to take advantage during your training, understanding healthcare finance, because ultimately that is where the change happens. If you can't finance it, it cannot be sustainable, period. So I do think as public health leaders, we have to spend the time in our I did not have that education in my training. But of course I didn't go to Tulane, so I would have gotten it here. But I think that that's a really important thing, is to understand it, learn it, be curious. You don't have to have an MBA. I don't have an MBA. But I've gotten one through osmosis because I had to. And so I think the more you can read, the more you can understand. Read the Wall Street Journal, read earnings reports, learn what a balance sheet. I mean, Adaeze is so much more expert at this. And when we say private equity, what we mean are organizations that invest in companies that are making hundreds of millions a year, versus venture will fund you if you're making, what we do this year will make about 14 million, right? So companies like us that are under 100 million, that are small, I don't know where you are on this, but those small companies that are on that early journey is what venture does. But understanding it is how you do it, and then go work for one. Go work as a chief of staff, go work as an analyst, go work as whatever. And often you don't even have to move to do it. A lot of our staff is remote. So yeah.
Mm-hmm.
It's a great question. It's a great push, actually, right? If you don't have this background, I think the fact that I came into it later, and you too, we came into this a little bit later we're not 30. Shocking.
Nah.
You're not 30. A lot of the CEOs in this space are quite young. I wouldn't choose to do this as a 30-year-old. Infinitely wiser today than I was at 30. And I think that what you're calling out, Tom, is the kind of network you can draw. There's certain conversations I can have in a boardroom today that I would not have conceived of as a young person, without network, without, frankly, just a resume and other things I can do should this discussion end today, right?
But most of these founders younger than 30?
Most, no,
So,
they're
so
not
why
young,
would you? Well, many of them, many
maybe
people.
young.
So
Maybe in
why
their
would you
30s.
suggest that they not try startups for 30?
Think it's not that. I think that perhaps there's a challenge in, let me put it this way. In healthcare, I think in tech it's different.
Mm-hmm.
In healthcare, if you don't understand the business of healthcare, it is very difficult to succeed. And you're probably not going to have that if you don't have the prerequisite education and exposure to the healthcare system, whether from a provider perspective, a health plan perspective, if you're coming from business, investment banking, venture, private equity, and even then, any single one of those is insufficient as a means of exposure. So I think healthcare is different from, say, tech, where you're just building a product and putting it out. I do think you see a lot of 30-year-olds who can make it. In healthcare, I think you just need to know more. This is why it's hard for us to hire people from outside. I keep daydreaming about hiring someone from finance or financial services or consumer products because, they'll come with this great training and a great operator. The moment I have to tell them this is what a health insurance company does, there's just no way that this could work. You need to have a depth of expertise and experience in the healthcare space. And so it's not that I say to any 30-year-old, don't do it. I just think there's just a gap there that you need to close. And there are many of them.
Understand the business.
There are many of them. Yeah.
One thing, Tom, I'll say just for those of you who are interested, there's a fabulous podcast called Acquired, and I geek out on it a lot, but it's a story of Costco and Trader Joe's. And I really have learned a lot from it because I think every story is different. Every founder's story is different. If you look at something like PayPal, for example, almost all of Silicon Valley came from, like there are places and there are renaissances in the startup world. But in healthcare, that's just not so true, as Adaeze said. But I do think if you're interested in it, you'll hear a lot of the how did they start it, right? How did it happen? What were the circumstances? Because they're all so unique.
So, no, go ahead.
I was just gonna say, when I got called, I told this, my funny story about how I got into private equity, which, if you know anything about PE, no, they don't look like me. Again, and that's fine. Before I joined, I took it upon myself to basically put myself through school. Because I didn't come from investment banking. I didn't work in a venture. And even if I had been in venture, frankly, venture and private equity are very different. I listened to podcasts, Dry Powder, Bain Capital, listened to that every day, read books on it, try to understand the levers and how you can basically create the right incentives and get some of the desired outcomes that you would want to see. I'm not the corporate raider that lots of people imagine when they think about a private equity investor. Not all of them are. But at the same time, I think even at that level, even as someone who has been around for 20-something years, I felt very much like a student and wanted to walk in, learn, and give myself some time to be conversant in the language. And I thought I knew everything about healthcare. I'd run healthcare for the country. I walk into my first PE meeting. It was a completely different language. Every word I needed to take notes, call my partners and say, what does this mean? What does this mean? How do you assess this company? How do you assess value? How do you price? Private equity is a function of pricing assets, pricing a company when you know everything that is possible to know about the company. There is no health econ or health policy class that'll teach you that. And so giving yourself the space to learn, I think, is one of the key things for anyone looking to branch into this space.
So one of the things that happens with when new innovations are created is that they tend to actually expand inequity, because usually the most advantaged get access first, and I think it makes things worse. Both of you have, throughout your careers in public health, have been very much working in health equity. So I know that it's part of your DNA. How do you ensure that the work that you're doing doesn't actually turn out expanding health inequities?
Well, I mean, for us, I always say we're not for the Lululemon mom. Like, if you can afford Lululemon, we're not taking care of you. Like, that is very
Yeah,
It's
but you're not
intentional.
going to get everybody. There'll still be,
No, but we only do Medicaid. That is our why. And that
right.
was very intentional. We will talk about this. There are a lot of companies out there. Now, first of all, Medicaid's $1 trillion business. There's a lot of money in Medicaid. Half of American pregnant women are in Medicaid, 60% in Louisiana. So this is a lot of money. It's big money. And a lot of companies go out there and say, we want to take care of the Lululemon mom and do concierge care. And then we're just going to eke into Medicaid and just figure it out. No, because it's really hard. And Medicaid is policy, politics, and payment. And it's all important. And you can't do the payment without the politics. And you can't do the policy without the payment, and vice versa. You have to know it. There are very few people in this country that do. And so we at Nest are uniquely suited to take it on, but that is our why. No, nobody on my team, including me, would be working at this company if we were doing that, because A, they don't need it. And by the way, you know, one of the things that we find is that it's worse than we thought. When we go into homes here in New Orleans, it's worse than we thought. There are no toys. There is no furniture. There are no resources. In a state that says every birth at all costs, or else you'll go to jail if you don't want to have it, right? And we care about babies so much. Okay, how come we have kids going hungry that live, you know, less than a mile from here, and they have no toys and no books and nobody there to help them? So it just makes me mad as hell. But the point is that that's our why, and we're not doing it. And the model works better in Medicaid too. So what you do is you create a model that works for Medicaid if you want to take care of Medicaid. And the reason ours works for Medicaid is in Medicaid, and public health geeks, stay with me here, quality matters, right? Quality, these health plans get paid on quality. If you put a vaccine in an arm or you do a well child visit, they care about it. Whereas frankly, in commercial, they don't. And because it's hard to save money on kids, right? Why is that? Because kids don't tend to have chronic diseases. We have to have quality as part of our value. So, you know, I think that that's important. You have to be intentional about it. And we don't have competitors so much, but those that say they want to do it are really hitting into walls because they don't understand it.
I would underscore everything Rebekah just said. I think for us, we're also Medicaid. I actually had to make an affirmative decision to sunset a commercial contract. It was that much of a distraction. So you would think that perhaps in a commercially insured population that's Medicaid adjacent in terms of how they show up, their profile, that you can sort of make it work. In reality, it's actually difficult to do. We are purpose-built for a Medicaid population. And I'll tell you, in industry, any company that starts off with commercial as our primary, but we're doing Medicaid as a side gig. It doesn't work. You can even look at their website will tell you just the way it shows up, the product, if they have an app, the way that they organize their teams, the inputs you consider, how you design your model are necessarily different when you are serving a Medicaid population where the payment structure is going to be different. It's going to be different. So if you tell me right now to switch entirely to fee-for-service, I won't take that contract. It doesn't work. Fee-for-service is also what we're trying to move away from. You'd be surprised how often health plans want to pay you on a fee-for-service basis, because that's the legacy payment infrastructure, so it's easier for them. But it defeats the purpose. We need to be able to address whatever comes up. We are in DC, Maryland, Tennessee. Our moms are very they value highly the services that we provide for them. We can't be shackled to a minute, we bill in increments, we bill in sometimes it's an hour. And sometimes a nurse, while she's there, something breaks out, she stays for 2 hours. And we need to have the flexibility to serve our moms, irrespective of the circumstances that might pop up in the course of the day.
Okay, so let's turn to the audience. Maybe we can get the microphone going, and if you want to ask a question, please raise your hand. We'll bring the microphone. We have one here in the front. So while we do that, let me ask one last question, then we'll open it up. So what public health challenges do you think are ripe for entrepreneurial intervention?
I mean, what about when COVID hits again? I mean, can someone please work on that? Surveillance system, and that's duh. And then I think in terms of public health, ideally we figure out some ways to privatize public health, because public health, as we've seen across the country, has been, on the chopping block. and under attack. And so I don't know exactly, but just to say, how do we think, when we think about surveillance, data analytics, keeping people enrolled, behavioral, I'm on the board of, or was on the board of Cayaba at Penn, which is the Center for Behavioral Economics. How do we use behavioral economic principles to get people to do things we want them to do? All of those things are very, very important. Motivations for why people are, how to motivate them to be healthy, how to motivate them to get care, and also obviously how to change the circumstances of their lives so that it's possible for them to want that. All of that's ripe for innovation.
Okay. Let's go to this question. First question.
Hi, thanks very much. I think you addressed to some extent this question at the very end, which was basically, how do y'all get paid?
How do we get paid?
The profit motive seems that it mainly works on reducing costs, which often leads to reducing quality.
Mhm.
But you're saying that you're actually having to increase quality. Seems like it's almost anti-capitalist.
Oh no, this is very capitalist. I mean, it's
Yeah.
so you let me answer the question a couple different ways. I think you're asking the contract, like what's the how do we, what kinds of contracts we sign? Is that the question?
No, so is that never fee for service?
Yeah, it's not fee for service. So there are a couple of different ways. A value-based care, Rebekah can talk about some of her, and every contract could look different. For us right now, it's actually a per enrolled member per month. So it's a case rate. So the case rates allows you, and you have actuarial analysis to make sure that you can deliver the services that you need to deliver during that episode to achieve the outcomes that you are promising and you're accountable for achieving under the venture margin profile that you were required to deliver on. So investors who invest in this company expecting that this is essentially the margin profile, especially after the care delivery, not just managing the business. I'm certainly assessed on that. How do you manage finances? How do you manage the business? How do you manage costs in terms of running the company? But the care margin, how can you deliver these services on a per month basis over an episode and still hit a certain margin profile? And so we bake that into the range of rates that we discuss with health plans.
Yeah, pretty much the same per member per month. Could be per engaged member per month. Sometimes it's fee for service with a per engaged fee. But yeah, we price it so that we have healthy margin. And then we go risk for some of our fees. So we basically tell our payer, if we don't save you money, we'll pay part of it back. Yeah.
We have an outcomes-based, sort of accountability function in our contract.
Yeah.
Okay. My question is about how we can learn from some of the innovations around the world. Both of your companies remind me a lot of the community health worker models that are operating in low and middle income countries. And in the US, we tend to think that we're unique and special. And I wonder if there's a way that you think we can start to learn from folks who are experiencing similar conditions around the world.
I love that question. My name, Adaeze, is an Igbo name. I'm Nigerian. I'm West African. So I'm not under any illusion about this being, unique. This is 1/10 of what would happen to a pregnant mom in my culture. The moment you announce you're pregnant in Igbo culture, you can basically sit down, put your feet up, and the world will just surround you. And when that baby's born, you have to beg to see your baby. They basically bring the baby to you to breastfeed, and then somebody takes the baby.
Yeah.
And so our culture and some of the cultural sort of that wraparound, essentially. I mean, that's why I've been wedded to the word wraparound, is because in many cultures where people are much poorer, right, in terms of cash, the notion that you would be alone during pregnancy or alone at birth is inconceivable. It's very inhumane as far as I'm concerned. And so that sort of surrounding the mom with love, with someone who's more of a peer, who can speak with you with empathy, who's not going to judge you, comes naturally to me. It's what I witnessed, it's what my mother did for me, it's what I witnessed with my mother when she had the youngest siblings. And it's very normal in many cultures. I was interviewing a Chinese student at Penn, at Wharton, and it was interesting. When I was describing the model, like what we do, She didn't understand that this wasn't standard. She didn't understand why this is a company.
Yeah.
And she said, so why? Why does anybody need to pay for this? How is this a company? And I laughed and had to remind myself, I am speaking to someone who is also international, for whom this is a foreign concept, but that's not the reality here. We are very much alone and sort of at the mercy of a broken healthcare system.
Yeah, I was just saying we are uniquely bad in the US. So I looked to Alaska, which you could argue it's kind of the US, but I mean, does not represent most of healthcare in this country. And then I had studied as a public health, I would really encourage you as students to get out of here and go to interesting places. I worked and lived in Cuba. I worked and lived in Ecuador. I learned more from those two experiences than from my degree. No offense, degrees are important too, but what I learned is invaluable. And also lived in France. And so, yeah, I mean, you see it and you're like, wow, this is just so dumb. And like in Germany, you have the Hebammes, right? Who are the midwives. You have, in almost every country on earth, you have supports for families. So I also think it's perfectly okay to steal from that, right? Whether it's Kerala in India or these great places or Nigeria, we deserve the same, but you don't have to come up with something brand new. I said that's actually a lot of opportunity to take these models that have been much more successful at a much lower cost in international frameworks and bring them here. Now, who's not going to do that? The hospitals and health systems. That's why I think it's a great way. And your model, I guess I didn't think about it. Both of us, our models share that.
Okay, we think we have time for one more question. Maybe we can slip in. Anyone else? Okay, then I'll take it. If you could redesign any part of the public health care, I'm going to say system, or we don't really have a system, but I think you know what I mean. If you were going to could redesign any part of it from scratch, what would you select to redesign it?
This won't surprise you. I'd start with the purchaser. The insurance system that we have, insurance and insurers have, I think when you're in public health, you don't fully appreciate the outsized influence insurers have on the delivery of medical care, the delivery of health care, and frankly, even the public health system. And I'm not here to advocate whether it's a single payer system or not, but the system we have today is it is by design. This is exactly the system that has been designed, right? So when we are getting the outcomes we get because of the way we purchase healthcare. So I would just go back to the drawing board and say, what are we paying for? Is it what people want? Is it what people need? And if what we're paying for is neither of those things, how do we build in flexibilities to address actual wellness and well care, as opposed to just healthcare services? I think that, to me, I think the beginning and the end of our issue is really with how we pay for services.
Well, I think we need to redefine healthcare. Healthcare is not healthcare services. Healthcare is public health. Healthcare is people getting what they need. And if we were to have that attitude, and honestly, very similar to what Cuba has, is like first you talk about nutrition and well-being, and then you talk about let's treat it with a drug. That's what we need, and that's what we would be able to change outcomes so dramatically. I think the other piece is we are burying our country under the cost of this thing. I learned just a quick learning that I had when I was Secretary of Health. Someone wanted to build 2 proton beams down here. One, because Oxford and LCMC were getting in a testosterone fight. And I said, well, how many people actually need this proton beam? They're like, well, 5 per month. And I was like, are you kidding me? $300 million on 10 people in the city of New Orleans is silly. And it was like, well, but then the head of economic development came to me and said, well, but this is great. We're going to create all these jobs. And I was like, well, who's going to pay for those jobs? It's the taxpayer. It's Medicare and Medicaid. So anyway, I think if we could actually be realistic about what all this money is for and who it's going to and what it's doing, and we had health as the function, not health services, we would have a very different world. And I don't know how we got there, frankly. I am now kind of given up and saying we have to do incrementalism as it relates to this, because there's just too much money. Unless there's some really global catastrophe. Europe fortunately did reorganize itself around World War II. We have not had the wherewithal to do that, but we are really messed up in terms of who is making money and how much money they're making and why they're making money. So that has to change.
Okay. Big, big thank you to everyone. And I believe we have refreshments outside in the reception. So please join us out for reception. Thank you.
Thank you.